there's a big gap. And we are told to cover this gap. And now I'm going to superimpose on this map the map of where our patients are coming from. And I think that we meet the need by looking from where the patients come from, covering, I would say, more than what we say initially about the 10% about the other specialties when it comes to heart failure and transplant. We cover, as you can see here, we get referrals from 27 states. I would say at least a dozen of those are referring actively all the time. And RVA, which is the same program as us, is one of the 5 VAs in the country offering advanced therapies. So that's why we get patients from Alaska and Hawaii as well, all the way from Houston and Dallas. And more than 70% of our patients come from out of the state. Quickly, I'm going to go through the fact that we have more than half a century of experience in mechanical support, and we will see a little bit later how this started. We have more than 100 patients right now that they are ongoing as outpatients with mechanical circulatory support. And we do around 40 durable VADS per year with another 100 to 80 to 100 short-term support devices after shock or other circulatory collapses. And these are the people that they put together the program. And you can see that we have surgeons, cardiologists, nurse coordinators, and we cannot list everybody here, but I'll show you a picture later. More than 30 people every week meet together to discuss about our patients. We train a lot of people within our institution and outside our institution. You know, I think that this is probably the most rewarding thing that we do. And these are just the last 3 years. We had people trained to start advanced heart failure and mechanical support programs from China, Panama, Greece, and Chile. This is the picture of our colleagues from Chile with Omar, who is sitting there, and Hossein Ativi, who gave the amyloid talk last year at US Symposium. And these are the colleagues from China with our surgeons that they trained, and they went back to start one of the heart at the first VAD programs in that country. And we don't train only the people that they come from around the world, we also train our own people. And after we train them, we either recruit them, like Dr. Nativi and Dr. Weaver-Pinzon, that you met and you will meet. And of course, we also send people to other centers. And you can see here the last few years, some of our trainees that they are now independent faculty. So the first part of the talk will be about acute heart failure and shock. And we're going to start with something new that we're doing, which is the shock team. And I put there institutional cultural change because that's what it takes if you really want to have a real team to take care of these sick patients. But I'm sure that you get here as well. So I'm going to divide this in 3 parts. And first, I'm going to start with the rationale. So the causes of shock, as we all know, vary. And there's all these causes that can get a patient into cardiogenic shock. So the types of ventricular failure, when you get into shock, also vary. These pictures are meant to be still. And you can see here the left ventricle dilated. You see that when you see a patient with a shock, and then you say, probably this is acute on chronic. It's already dilated. And then this is another patient with shock, and the LV is not dilated. The RV is dilated here. So the patient is still in shock, but the problem here is not the LV. The left is the right. And here is another example of a patient in shock where there's neither the left nor the right dilated. The problem here is that there's not enough filling and relaxation of the heart because this is an infiltrated cardiomyopathy, again, because of shock. So we have variability in the causes and the types of ventricular failure. And just to make the point about the complexity, the options we have to treat these patients are also variable. And then when you go and talk about shock, you're not talking just about the heart. You're talking about the periphery, you're talking about the lungs, you're talking about trying to support these organs with ventilators, with dialysis, with mechanical circulatory support options. And then when you talk about mechanical circulatory support options, you talk about both the left and the right. And this is examples, and we will talk later in a case that you can support the left side of the heart. And you can see that we have more than one options, adding to the complexity, right? And we also have options that they require cardiology and cath lab or surgery. And when you put everything together and you add to this the age, the comorbidities, additional factors, adding to the complexity, the psychosocial situation, and the exit strategy. And the exit strategy could be a bridge to a mechanical assist device or transplant or recovery. Then it's easy to understand that this is a little bit more complex than what one person would like to handle by him or herself. Do we have any favorable experience in our systems with other teams? As you can see here, we do have favorable experiences with other teams in our health systems. Again, building the rationale why shock team makes sense. And then if you go to the guidelines, you see that we have not really good evidence to guide what we need to do. And most of the guidelines have evidence level C or B, meaning that we don't have randomized controlled trials to tell us what to do, which makes it even more difficult in the middle of the night, somebody by him or herself making decisions in a patient who is between life and death. So I hope that I gave you a taste of the complexity of the care and the other components of why we think a shock team makes sense. And now, moving to the practical aspects of how to develop a shock team, I'm going to start with the goals of the shock team, which, if we put them in an order, you need to be able to identify the problem quickly and go after the etiology and the root cause, if you can. Be able, if you need to revascularize or provide supportive care, so the problem is a blockage of the coronaries, which is not always the case. And then have a plan for escalation with whatever options you have available. And always you need to be aware that you may need to make difficult decisions and withdraw care. And these are difficult discussions to happen in the middle of the night when family might not be around and the patient might be doing poorly. So the core members of the shock team, in most places, we started this 3.5, 4 years ago, and now more and more places are starting. So it's a heart failure cardiologist, an interventional cardiologist, a heart failure surgeon, and a critical care specialist, cardiac ICU attending. These can change from institution to institution based on what specialties are more active in this institution. But usually the core members are those. And we can talk more about, because we've been giving this talk to community hospitals, but they don't have the army of the fellows and the specialties the tertiary care hospital might have. And I think that's something that we can discuss more. The infrastructure to build the shock team is also very important. And you need to have the culture to work together between the ICU, the OR, the ER, and the cath lab. So I'm going to share with you our algorithm, which we think is practical and simple. We spend a lot of time to put it together because we wanted it to be practical, and it's easy to add things. It's not easy to remove things, to make things simple and practical. So in order to make it simple and practical, there's no criterion of when to activate the shock team. No criterion. So the instructions to the fellows, to the residents, to the attendings, to everybody have a very low threshold. Whenever something smells bad, just activate the shock team. It's just a discussion. It's not like activating the cath lab or saying everybody rushing from home. It's just a discussion between the fellows and the attendings in charge, comprising the shock team as we discussed. So the idea is to be able to catch these situations early. So if you just begin putting their criteria and complexity and people remembering the blood pressure and the drip doses and everything, whenever you see somebody with tachycardia or a hypertension, or just activate the shock team. So this has been working now for 4 years very well. I'll show you some results. So the heart failure attending, the interventional attending, and the CVICU attending, and the heart surgeon are getting together over the phone if it's after hours, or going to the bedside if it's working time. And then the next decision point is whether this is a STEMI or anything else. The non-ST elevation MI also goes with the anything else. So let's start with the situation that we have shock without ST elevation MI. In this case, we always do a right heart cath, and we leave this one in. And then if indicated, it says there MCS, which stands for mechanical circulatory support. So in our center, nobody knows when to use MCS in shock because we have not done the studies yet. So we don't know what is the indication to use it. But we consider it when somebody meets this criteria. And where we got this criteria? From the balloon pump STEMI shock trial, the last one that was published a couple of years ago in New England, where these criteria meant 50% mortality. So when you have 1 in 2 dying, then you may consider, in the absence of randomized data, to use this criteria. And of course, we have our registry and we are collecting the data. So that's what we use. This is the hemodynamics by systemic blood pressure. And of course, we use one of the following. It says there wedge or LVDP more than 15 and the index less than 2.2, or clinical signs of pulmonary edema or impaired end organ perfusion. So when we see that, we consider using MCS. And we don't say what type of MCS. Impella, ECMO, we'll talk about it later, because again, we don't really have evidence suggesting what is best to use. So we leave this on the wisdom of the team. What the team knows to do better that night, the people that are on call. And based on the scenario and what we know already, they make a decision of what they think it works the best. Again, in the absence of randomized data. And if the patient has STEMI and time is muscle, then the algorithm changes a little bit. We don't have the time to do a right heart cath before we revascularize. So we still not, though, because the patient is in shock, want some information for the blue box there. So the compromise, we had a meeting like this. The interventional cardiologist came, the heart failure cardiologist came, the surgeons came, the nurses, everyone. So we're discussing what to do in the STEMI when we have shock. And the compromise between the interventional cardiologists who want to go open the vessel immediately and the others that they want to get some information is not to do a right heart cath and lose the time, to do a right heart cath before the angiogram. But when you are with access in the arterial system, you just push and get an LVDP for us. It's going to take 5 more seconds. And then you can continue with your planning. And if the LVDP is more than 15, you're not going to get the index. It's the only thing that we are going to be missing, but you will have all of the other things, and then you can make the decision. And when the angiogram and the PCI is done, if the patient meets this criteria, at the same time, we try to employ the mechanical circulatory support, and then after we're done with this, and the angiogram and the PCI is done, then you can do your right heart cath from the neck vein and leave this one in to help you with managing the patient in the ICU. So that's our algorithm. Very simple. And we summarize this algorithm in a card, pocket card that we can share with you, and all of our fellows, residents, and faculty to carry. And it's been working so far very well. I'll show you a case, and then I'll show you the first results we just published in Circulatory. So that's a case that came from a hospital. It could have been your hospital. You saw the occluded. Let me go back. You saw the occluded RCA in the outside hospital. They revascularize. You may have seen there that there is some clot that remained there after the revascularization, which probably was why a few hours later this patient get again chest pain. They did another angiogram, and the patient had re-occluded his RCA. Patient was in shock, so he was transferred to our institution. That's how the system works. Shock team was paged. You get the age of the patient, the name, and the callback from our fellow. This is how the patient looked when he arrived in our institution. The blood pressure was 88, heart rate 110. You can see the echo showing the RV struggling, and the EKG. Omar was the heart failure and CVICU attending on call that day. Anwar was one of our interventional cardiologists, and Craig Silsman, who comes here once a year for a week with you, was the heart failure surgeon on call. They got together, they cut the patient. You already knew the blood pressure and the heart rate from before. The RA was 16, the systolic PA was only 23, and the index was very low, 1.5, clearly showing that this RV is not working. So it's not generating pressure, that's why the PA is so low. It's not normal PA. You would see it and say it's normal. No, it's not normal. In the evidence of this low cardiac index and the high RA, then you know that this is an RV that is failing big time. So with that in mind, the options that the shock team discussed was reattempt the PCI and use an option for RV support like the Impella, or go in the OR to put a surgical right ventricular assist device and do a TAP. Between the two, the team decided that night to go with the less invasive approach. These are the options that we have nowadays in our institution. We have the Impella RP, which gets the blood from the IVC, get it to the PA artery. Protect Duo is something we don't have in our institution and we're going to bring very soon, which is again helping the RV by getting the blood from the RA to the pulmonary artery. And of course, the ECMO, the VA ECMO, the venous arterial ECMO is another option that we could have considered. We decided that day to go with the RP Impella. And that's how it looked in our patient. This man is meant to be still getting the blood from the IVC to the pulmonary artery, bypassing the failing RV. So one of the problems with the Impella RP versus the Protect Duo that I showed you before is that the patient needs to be ambulatory. So 17 days later, the patient was still lying in bed, doing better. It was not in shock, but the RV was not good enough to win the Impella. And now the shock team gets again together to see what are we going to do with this patient after 17 days not ambulating, extubated, feeling well, but not being able to win the pump. So I was on call for heart failure in ICU. Fred Weld was our interventional cath lab director attending, and Antigone was one other heart failure surgeon on call that day. So the options we discussed was to do viability and do a CABG now. The other option was to continue the RV support and upgrade to a surgical VAD like the Centrimac where the patient can walk. And the third option to list the patient for heart transplantation. So we elected to do the second and started the process for the third that takes some time, listing the patient, to give to the RV more time to recover. And indeed, the right VAD was implanted, and this is how it looks. The good thing with the surgical right VAD is that despite the extracorporeal circulation, the patient can ambulate in the ICU. We had a patient in RVA 6 months with this waiting for transplant. So it's something that you can ambulate the patient, and 31 days later, the RV recovers. You know, the RV sometimes can delay a lot to recover. And I saw the patient in clinic. This is 5 days after the explantation. The echo you saw moving well, and I saw the patient in clinic very recently doing fine. So what are the data we have on the effectiveness of the shock team? This is a paper that just came out in Circulation, and we had 123 patients, and we compared them with another 123 patients the first 123 got the shock team approach since 2015 when we started that, and the other 123 were the ones before we started the shock. So you can see that 60% of the patients were with acute coronary syndrome, and the other 40% of the patients had other etiologies of shock, like acute or chronic, diabetes. And we're talking about real shock. I mean, 47% of the patients got CPR, and 66% of the patients were on a ventilator. Where's the lactate? Yeah, it's covered here. So the lactate was around 5. The patient was really like a real shock. So one of the outcomes we measured was the time to support time. And the reason we did that is because I was giving this talk in Columbia, where Jason came from, and one of his buddies there told me, you guys in Utah are nice, talk to each other, but by the time we get together in New York, he was telling me, and agree what we're going to do, the patient will. So the too many cooks in the kitchen argument was a concern from the early days that people were talking about the shock team. That you don't have one single individual making decisions quickly. And when people don't agree, what are you going to do? That's why we talk about the culture of change at the beginning. So in our hands, the shock to support time, if anything, goes shorter with the shock and not longer, which is a critical decision. And we are looking also in other decisions at the delays. We didn't have any delays. So in our shock team approach, we had 50% relative reduction of mortality. You can see the survival here better. And this is the central illustration of the publication in Circulation. And the local press also gave it a lot of publicity when it was published about the way we approach these mortally sick patients. So in summary, it makes sense. And we reviewed together the rationale. The actions to develop a shock team, we saw them, it's feasible. We've been having it now for almost 4 years without any glitches. And of course requires coordination and a cultural change so people can get to work together. And the outcomes are promising, but of course we need prospective randomized studies. So with this, and before I move to the chronic heart failure and the chronic and the other part of the talk, I'd like to pause here and open it to questions about what we reviewed so far.
Okay. So relatively, in our institution here where we don't have, LVADs and those types of assist devices, when would you feel it's appropriate for us to transfer patients from here to you? We maximize our therapies here. Do you want to see them early? When do you prefer to have them come in Utah?
That's a great question. And I'll have a dedicated slide about this when it comes to the chronic heart failure patients, where you have time to think and evaluate the patient. And then I would say completing most of the evaluation here, you have a great place, would be the way to go. And I'll share this with you later. But when it comes to shock, I think that it depends on the options that you have from what I reviewed there and the level that you think of support you can provide here. One of the talks that we will have in UCARs this year, it's going to be about the classification of the severity of shock. It's a common joke when we talk about shock. This is a shock patient, this is another shock patient, this is a severe shock patient, this is the shock patient. They're all different. So they just classified it and they just published that in JACC in 5 categories, 5 different categories of shock. So it depends. I mean, if you have a patient that is crashing and burning, you're not going to be able to transfer this patient. So you need to do everything you can in order to stabilize the patient. I would say that stable patients, that the exit strategy doesn't seem to be quick bridge to recovery, transferring them is a way to go after you stabilize them, either with ECMO or with whatever you have the ability to do. Sometimes we even send a team from our hospital to stabilize patients, which is something we can discuss more offline. But I would say that when the exit strategy doesn't seem to be bridge to recovery quickly, I would say transferring the patient is the way to go because this patient may need advanced therapies, durable advanced therapies, or upgrade to short-term support that is more powerful. Omar, Jason, do you want to add something to that, or Camila, or Angela?
We transfer a lot of patients, and what Dr. Drakos was talking about, we have a flight team of nurses and a surgeon who come out in acute phase. If I heard you correctly, you said you don't have some of these capabilities. So because we know you well and you'll have our contact information, we could come directly to you and be that extension of what you might need and provide those things for you.
So if we don't have, I see one more hand now. If we don't have more questions, I can just move to the second part, which is about the chronic heart failure. So these people, even if they survive with a damaged heart. And that's one of the reasons that the etiology of chronic heart failure is going up. It's illustrated here very nicely. The last 20, 30 years, the coronary deaths are down by half, and heart failure has almost tripled because we don't lose as many STEMIs, and even if they go to shock, because of all these approaches now, you see that we might get better results. So we help people survive with injured heart. So that's why the chronic heart failure goes up. So nowadays, 1 in 5 over 40 will have heart failure. So there are people here with heart failure now, right? At least 1 in 5 over 40. Most common hospital admission, and 10% of the hospital deaths, if you just go in your hospital now, 10% of the people in the hospital at any ward will have in their past medical history chronic heart failure. It costs 30 billion, and the projection is it's going to go to 17 to 2030, and it costs more than all cancers combined. It costs more than all cancers combined. The British like to make this point all the time. They are good at raising money. When it reaches the end stage, which is what we're talking about here, the mortality is like the lung cancer and the pancreatic cancer, and we tend to forget that sometimes, that a class 4 patient will have likelihood to die as much as a pancreatic cancer or a lung cancer patient. And we're here to talk about advanced therapies and mechanical circulatory support and VADS, and these are the stages and all of the things that we do with medications, with resynchronization therapy, with mitral clip, with all. We're not going to talk about these things together. Jason might touch on some of the valve therapies, but when the patient reaches the stage D, then valve and transplantation are becoming the gold standard options. And the problem with heart transplantation is that it's impossible to meet the need. We have 3,000 to 4,000 transplants per year, and we have, the estimation is between 75 and 100,000 people in need. So the transplantation cannot meet the need. That's why you get covers like this one, listed patients like Lisa, waiting for a heart and dying, waiting for a heart. So in our institution, I showed you before the innovation and the contributions over the last 60 years, we are proud about our contribution to the evolution of the mechanical circulatory support field. So this is Willem Kolff. He's the father of dialysis and artificial organs. He was passionate not just about dialysis. He came from the Netherlands. He started the famous Department of Artificial Organs at the University of Utah, and the concept was to use technology to replace biology. So the first success they had, as we said before, was the balloon pump. This is Milopoulos, who was the guy, the first author on the balloon pump paper in dogs. And that was the first big success they had that encouraged them to continue to build the total artificial heart. And so the total artificial heart was a story that started in the mid-60s, and the first artificial heart went into Barney Clark, as you may recall, a dentist from Seattle. This is Bill DeVries, the surgeon. Kolff there, this is the New England paper describing a media sensation. The president came, more than 1,000 journalists from all over the world at the U. This is the people that did the work on the vaccine celebrating in this party, some of our mentors there, the big success. They were working for more than 2 decades to develop the total artificial heart. Nowadays, the flip evolved. We have the modern era. We're using ventricular assist devices. We don't replace the heart. We leave the heart there, and the pump is just sucking the blood from the left ventricle and diverting it to the aorta, right? That's what we do now. We have the modern era. And we're going to review quickly the 3 indications we have. The first 2 is either bridge to transplant or destination therapy, lifetime therapy. So the field is evolving through 3 avenues: technology, patient management getting better, and patient selection. I'm going to start with the technology. Now we have this device called HeartMate 3, and Momentum 3 was a trial that just came out a year ago now? No, March, so not even a year ago. So in this trial, we randomized 500 patients to this device and another 500 patients to the device we had before called HeartMate 2. And the differences between these devices, this device, the new one is centrifugal, and the other one is axial flow. They're both continuous flow pumps. And the results revealed that this new device is better, and you can see here the primary outcome, patients with event-free survival at 2 years. And you can see the benefit from this new pump at 2 years of follow-up. And to put this in perspective, This is an important slide. This is the 2-year survival with OMM, optimal medical therapy. We said that it's the cancer of the heart. It's not good. You can see here with blue, the HeartMate 3 survival 83% at 2 years. And with black, I superimpose there the heart transplantation survival. And this is an extrapolation, of course, because this study doesn't include heart transplantation as another arm to study, but it calls for maybe down the road a study which is going to head-to-head compare heart transplantation with mechanical circulatory support. Patient management. The patient management is the key to have good outcomes. Our team has published clinical care, impacting clinical care manuscripts over the last 10 years, I would say more than 80. And I'm just going to use some titles here. I'm not going to go through them in the interest of time. The reason I'm showing this is because we feel strongly that good clinical research makes the program have better results. And when we do clinical protocols, like the one we just finished with Camilla on the GI bleeding of these patients, we use not the data that we see out there, but primarily the data from our program. So that's what we did with the code program, protocol we have for LVAD patients, with the intracranial hemorrhage protocol, with our GI protocol that I just mentioned, and with the prevention and treatment of right ventricular failure when we support only the left with an LVAD. The same with the thrombosis, the pump thrombosis screening and management protocol. Patient selection. As in any other surgical approach, patient selection is very important. From all of the talk that we did, going back to Dave's question, this is probably the most important slide. This is when a patient with heart failure needs to be considered for evaluation from an advanced program. When the patient, of course, is an inotropes, it's easy. When the patient has persistently elevated BNP in class 3-4, when the end organs complain, like creatinine and BUN, when the EF is less than 35 and the patient is getting shocks, when you have more than one hospitalizations the last 6 months, when you have edema or elevated pulmonary artery pressures despite going up on diuretics, when the blood pressure is low and the heart rate is higher than the blood pressure, these are the occasions that you need really to consider that the patient needs to be transferred. I don't want to forget this last point, when the patient does not tolerate anymore medications that used to tolerate a few months ago, and you have to go down and take the patient off these medications. This is when you know that this patient is declining. And you should just consider this evaluation. It doesn't mean that this patient will end up with advanced therapies. And why do I say that? Because when we do our multidisciplinary meeting, more than 30 people in their own way, pros and cons, not everybody gets advanced therapies. I mean, you guys visited and you know that. We always send very frequently patients back saying, it's not beyond the red line yet, we have time. We need to do maybe one or other 2 things before. So we don't want to proceed to advanced therapies too early, but of course we don't want to go too late. We want this optimum window. And that's the bottom line. And that's the goal. That's what we are looking for. Our program, you can see here the outcomes versus the national average with blue. And we are proud to report that our survival is better than the national average. This is the quality of life and the functional capacity. We have people saying, are you just eating a dead horse? I mean, are these patients going to go out and do stuff? So you can see here the 6-minute walk test, the New York Heart Association class, the Kansas City questionnaire, and the EQ5, and you can see the improvement from before, and also the comparison with the national average with blue, which shows that these patients do have better quality of life and good exercise capacity. So that's a case, 79-year-old, came from St. Al's, a referral hospital like you. He had the history of lymphoma, low EF, high filling pressures, low index, came to us, max VO2 was 12, patient was not tolerating heart failure medications. He was inotrope dependent. He ended up with a DT LVAD. We discussed at our multidisciplinary meeting because the AI was moderate. We also our surgeons also fixed the valve. They put a bioprosthetic valve there. So 2 weeks later was discharged to the inpatient rehab, and 1 week later went to home. He's now 7 years out. The last 2 years, he didn't even come to Salt Lake City. Through this shared care model, he's been followed in sales. And that's one of the things that down the road, we can talk more. We can even have one of our coordinators here talk maybe next year about shared care. I'm just going to share 2 slides about what is shared care with you. So this is what you should expect when you work with us about shared care. The patient will be identified. You will screen for eligibility. We can talk. We do this with Dave and Dr. Chrysos and others here all the time. Patient will come. Expect the patient to stay in Salt Lake 1 to 3 months, depending on how bumpy will be the post, of course, and the rehab and everything. And then the patient comes back with one of our VAD coordinators. Our VAD coordinators are going to train everybody in the hospital, the fire department, education, and then there's going to be continuous communication between our staff and the referring providers and the team here. And this works. And so this is a paper that Omar and Angela and other members of our team, we put together to show that this shared care works. And if you divide centers in 3 levels, and we can talk later about these levels, I'm happy to have here people that they can go into detail about how we divide the levels of shared care. You will see that the local, which is our hospital, compared to the level 2 and level 3, that they don't come to our hospital and just stay in the shared care facility, they have equal outcomes. And only the level 1, which essentially there's no shared care there, has worse outcomes. So that's a message that shared care works. And it's not just being done for the convenience of the patient, which is important, of course. So the last echo of this patient showed an echo of 53%. Where did this come from? This is an end-stage patient who the heart was dying. So he gets an echo, and they call, the patient has an echo of 53%. So this brings us to the last part of this talk, which is the reverse remodeling and the recovery that happens sometimes in these patients. So you can see here this patient, you can see his heart, how it was before, and how it is now. You can see the squeezing here in the 4-chamber view, how improved. Not every patient is like this, but this patient responded. So what are we talking about is that we know that load is responsible for the progression of disease, and when we unload the heart, you might reverse and remodel. So the question is this something that we understand fully, and how can we go about it? If we step back and you go around in your hospital, when we talk about heart recovery, this is not an exotic thing. This is something that happens every day. When Jason is going to talk to you later about IES and fixing the aortic valve, this is the classic example of reversible cardiomyopathy. When somebody abstains from alcohol, that's another classic example of reversibility and recovery of the heart. When we use ERP, resynchronization therapy, that's another example. When we give beta blockers, that's another example. When the patient gets chemo and goes all peripartum and the patient, that's another example. We have a lot of examples. So the LVAD bridge to recovery is just a little bit more impressive because the patient is at stage. But the dogma that the human heart cannot recover has been cancelled and challenged many times in our everyday clinical practice. So this is in the 60s. And this is a circulation paper suggesting that when they didn't have anything but ditch and diuretics, bed rest improved the heart patients, the heart failure patients in this study. So this is the stage, the study we did with other centers in the country, bridging patients to recovery without LVADs and mediations. These were the criteria. We picked non-ischemic patients, less than 60 years old, low EF, big hearts, but less than 5 years sick. So they were not totally burned out. These were characteristics coming out from other studies that they predisposed patients to recover. We led the enrollment with Louisville and Penn. These are the explantation criteria. When the heart shrink, the EF improved by echo, and when we turn down the pump and we do a cut, the hemodynamics needed to be normal. When we saw that, we took the pumps out. This is the baseline characteristics, just to show you that the hearts were dilated. And you can see here the core lab was in New York, in Montefiore. that they read all of the echoes of all the patients. You can see how the EF went up in a proportion of the patients and how the heart shrink in a proportion of the patients. And the bottom line is that from the 36 people that they completed the protocol, 50% of them got their hearts out in all 6 institutions: Cleveland Clinic, Nebraska, Montefiore, Utah, Louisville, and Penn. And the primary outcome was what happened 1 year later. Because if we're going to take it out and 2 months later the patient is with heart failure, then it's not worth it. So 1 year later, 16 out of these 18 patients had freedom from heart failure recurrence, which is 89%. And now we are following them up to 4 years with good results. So you may ask me, that was a selected population. What happens in all comers, on all the patients that you see, ischemics and non-ischemics? So this is Anna and James. Anna is our, they used to be fellows with us, and we have used them, and they read thousands of echoes that you will see the results here. Anna now is the director of our echo lab. She may come next year to give a talk. And James, who is Omar's brother, graduated from us, and now he's junior faculty in the University of Florida in Gainesville. So we put, they put the bar high. All these people have low EF more than 40, and the shrinking of the heart more than 20%. And what we saw was that 5% of them improved if they had ischemic, and 20% improved if they had non-ischemic cardiomyopathy, an average of 15%. Omar did a study in the national registry with thousands of patients to confirm our Utah prospective results. 1% of the patients in this registry got recovery to lead to explantation. And people were saying, you told us that it's 15%. How the national registry has 1%. Well, not everybody has programs looking into recovery, right? So what Omar did, he took the other 15,000 patients, and he looked on the ones that they had follow-up echoes every 3 months to see what happened with these patients. And then what he found was that another 12% of these patients in the national registry, thousands of patients, they had an EF more than 40%. And they went again for transplant and other things because they didn't have a program for recovery. If you add the two, you will get 50%, which is very close to our program, which is focused on it and follows everybody in all this. So that was confirmed in the national registry. So what is the sustainability of this phenomenon? I showed you before the primary outcome at 1 year. So this is my mentor, Acute, who is a legend of cardiovascular disease and surgery. And the other alternative when the patient recovers on the VADS is to transplant the patient. So what he did here, he took 40 of the patients they explanted for recovery, and he compared them with 50 that they transplanted. And you can see over the years, similar results, which means that given that we don't have enough donors for everybody, we should give the donors to the ones that they don't recover and keep the ones that they recover with their own heart until the heart failure comes back, so we can transplant them. This is a study that we are going to do soon. How can we predict this recovery? So we can do the famous patient selection that we'll be talking all the time. So Omar again looked at the registry, and these are the characteristics he identified: younger patients, non-ischemic, shorter duration of disease, less dilated were the patients that they had the predisposition to respond. And in our hands, when this happens, we get a response rate when they have these characteristics up to 40%. So when you see these characteristics, this is where you can say to the patient, as we will see later, you may go for advanced therapies, but there's a chance that your heart will come back. All these patients are low EF, all of them. However, the heart rotates as well, torsion. Some of these patients, despite the low EF, they retain the torsion. What we show here is that these are the people that they recovered their hearts, the ones that they had low EF, but they retained the torsion, another predictor before the implantation. So we need to see these patients early, back to what you said today. Why? Because when we see these patients late, it's more difficult to reverse the remodel. If you see this patient earlier, before the heart is burned out, the recoverability, we have now lots of scientific data at the tissue gene level suggesting this, and that the recoverability will be higher. So currently, we see these patients late, with burned out, we remove the apex, because we take out the apex to put them up, right? Which, as we saw with the rotational mechanics, it's a crucial part of the heart function. We remove the apex, we see them burned out, and we still recover a good proportion of them. So we are getting now the minimal invasive pumps coming, that we're not going to remove the apex. We're going to do them in the cath lab or in the EP lab with a CRT device, and we will be able to move to patients that they're going to be less advanced, and there's a huge potential for this field in the future. Heart failure team, branding issue. somebody named us heart failure doctors, and now it's out and we cannot take it back. That's a problem we have in our field. You may have seen tweets and postings about it. Who did that? Well, they did it. In our program, we call heart failure and recovery because we need to add the optimism. Because we can recover hearts with medications, with all these things. So we have a branding issue. And so when we see a patient with end stage, you may talk to this patient about bridge to transplant and destination therapy, but you should also talk to him that there's a good chance to achieve heart recovery and get rid of the pump and abort the transplant plans. This changes the conversation and changes, even the cancer doctors talk about curing nowadays and long-term remission. So in summary, I hope I share with you enough data suggesting that the lifetime destination therapy now with the better pumps is a first-line option for selected patients. There are room for improvements through these three avenues that we discussed, and I hope to show you also that the bridge to recovery is an emerging, attractive pathway and option. David mentioned the UCARs, our symposium. This year is 16 and 17 of January. Of course, we do everything for our patients. That you can see them here. And our team, we do an annual funny picture. Camilla and Angela are good at that. They also throw some Greek parties sometimes. And this is the team, the whole team that you saw past years. And hopefully you will see more and more members of our team coming here over the years. And with this, I would like to thank you and open it again for questions.
Just a quick question. You mentioned about the rotational contractility of the heart, I was wondering, do you guys use a rotational strain pattern on the echo to determine that? Or like, is there a value cutoff that you look at?
That's a great question. And I have an expert here, the expert actually in echo, who's going to take care of it, given that he did most of the studies with the other fellow.
So yes, we're using strain, and we actually did a study which is published in, I think Stavros has a slide there, but where we look at the rotational strain, we look at rotational strain to predict who will recover. As patients with advanced heart failure, they lose that torsion, right? And we identify that patients, and we classify patients in patients who recover and who did not recover. And the patients who recover were patients that have preserved twist before the LVAD implantation. So yes, we use that as a one.
Is there a cutoff value for that?
Yes, it's a cutoff value. I believe it's 1.3. Not entirely sure, but yes, we have a cutoff value.
And we can send you the paper to see exactly the cutoff.
Circulation agent.
I wouldn't go on the cutoff. It's a continuous phenomenon. It's not all or none. So when you see it retain and it looks like it's not severely reduced, but is mildly to moderately, then you still have some recoverability there.
Okay, thank you.
And this idea we got from MI patients, that they showed the same thing.